I'll be co-hosting Airing Addiction with Lisa Blanchard.
No one story is the same as someone else's, but each journey is different.
Thing on the table.
Having run substance use treatment programs for over 20 years, trying to make sure that we are welcoming to all. I love the idea that kind of having that exposure and that affirming place, even for one person, impacts that milieu, which then can impact maybe the broader recovery community, the community at large. I mean, I really love that thought.
Good morning, everyone. My name is Cathy Collins, and welcome to our May podcast of Airing Addiction. I'm excited for today's guest, but before we turn it over to our guest, I'm going to introduce it to my co-host, Lisa Blanchard, who offers her take on the clinical side of things, while I offer my take on the recovery side of things. So, Lisa, take it away.
Thanks so much, Cathy. So I'm so pleased to introduce our guest today, Dr. Zlatina Kostova. She's the Director of Training and Trauma-Focused Cognitive Behavioral Therapy and an international trainer at the Child Trauma Training Center, which is out of the University of Massachusetts Medical School Department of Psychiatry. I've had the wonderful opportunity to co-present with Dr. Kostova on today's topic, and we've had such important conversations about the intersection of trauma and substance use disorder that we decided to take the conversation into the podcast. So before I move the discussion over to our esteemed guest, I would just like to give a little bit of a warning about the content today. There will be, some sensitive topics that we will talk about, and I just encourage viewers and listeners to take care of themselves. Press pause if you need to, do whatever it is that you need to do to take care of yourself as we have kind of some sensitive conversations. So with that, I'd love to turn it over to Zlatina. So can you tell us a little bit about your background?
Definitely. Thank you, Lisa. Thank you, Cathy. I'm so blessed and happy to be here today because I do think that the intersectionality between trauma and substance use disorder is so important and yet probably not completely enough explored. So I will start, I guess, by saying that I'm Bulgarian, and I am actually currently in Bulgaria, where it's afternoon. So afternoon to all the other people who are from the other side of the world. My background is in clinical psychology. I'm a licensed clinical psychologist in a couple of different countries in Europe, like Switzerland and Italy. And it's interesting because when I look back in my life, I am realizing that I lived in 4 different countries. So when I was 18, I went to Italy, which is one of the most beautiful countries that we have here in Europe. And I graduated in clinical psychology there. I did my bachelor's and master's degree. And then I moved to Switzerland, luckily the Italian-speaking part of Switzerland, so I didn't have to face the big loss of losing the Italian culture and language. And I did my Ph.D. there. And it was interesting because at the end of my PhD, I realized that I love academia and I love research, but I was missing a little bit the clinical piece. And I knew from the very beginning that I wanted to work with kids and adolescents. And then anyway, long story short, I had the opportunity to start my postdoctoral specialization at the Department of Psychiatry at the University of Massachusetts Medical School. And as I said, I knew that I wanted to work with kids and adolescents, but I was not quite sure exactly what I wanted to do and what type of population exactly what I wanted to work with. And then one of my first internships was in an inpatient psychiatric hospital for adolescents. And as you can imagine, those are the kids with the most traumatizing histories and very acute state of psychopathology with a lot of comorbid disorders. And it was really interesting because their program was very much trauma-informed. And that was the first time kind of that I've heard about trauma-informed care and trauma-informed therapies. And I became curious and I started to follow some trainings and conferences in this field. And something really clicked inside of me because I am a big believer that the experiences that we go through in our childhood and adolescence, both positive and negative, the way that we are raised, the models that we have seen in our lives can really impact the way that we think about ourselves, the way that we relate to other people. And so I thought that would be great for me, because I think that learning about trauma-informed care gives you those lenses that are really helpful for any type of professional who is working with individuals. So that was how I discovered a little bit myself and what I really wanted to do. And I started my specialization at the Child Trauma Training Center, where I currently work. And I can say a couple of words about this center because I think it's a great resource for people. And the first evidence-based treatment for trauma that I was trained was trauma-focused cognitive behavioral therapy, as you, Lisa, mentioned, this model TFCBT. And it's a model that incorporates a trauma narrative. So it kind of it's for kids and adolescents and also young adults, but it invites people to really talk about their traumatic experiences. And so I found that was really helpful, and I had some very successful cases. And anyway, I became an international trainer in TFCBT. So I feel like my clinical way of thinking, it's very much informed by these treatments. But anyway, just kind of a little introduction how I got into this field.
Thank you so much for that. Can you tell us a little bit about what you do now, right? What is it like to be an international trainer? Tell us a little bit about your work currently.
Yeah, absolutely. So as I mentioned, I'm directing the trainings at the Child Trauma Training Center. And this is a center where members of the National Child Stress Traumatic Network, which is the biggest network for childhood trauma. Oh. And essentially what we are doing is we are disseminating trainings essentially to all type of professionals out there in the world. We actually became just now a national center, so working with all the states in the United States and with me also internationally a little bit. But we are basically training all the professionals, starting from police officers through judges, pediatricians, DYS professionals, psychiatry residents, anyone out there who is working with children and families. And our goal is really to help professionals, number one, be aware of childhood trauma, what is childhood trauma, and all the impacts that can have on children, but also in a long term as adults. And then also give them the tools, how to assess it, what to do about it. And then we are also the biggest center disseminating trauma-focused cognitive behavioral therapy, as I mentioned. So we are also providing clinicians with the knowledge about what to do when you have kids and adolescents with trauma. So I am doing a lot of these trainings, and we also have a great resource. It's called LinkIt. It's a centralized referral system where basically anyone from the state can call us, and we will refer this particular child and family to specific agencies and clinicians that are certified or trained in trauma-informed therapies and care.
You said that really quickly. I wonder if you could repeat what the name of that link is.
It is called LinkKid.
LinkKid.
Yes. And if you Google LinkKid Child Trauma Training Center, you'll see a phone number and also a great online website where people can make a referral. It is absolutely for free, and we have some great referral coordinators that provide both psychoeducation and support to families and essentially linking them to services.
I think that is amazing. And just a quick question, because you said something that I thought was fascinating. You said initially you teach what is childhood trauma in the training. Can you, in a very short synopsis, tell us, like for the general public, what is childhood trauma? Is it emotional, physical, all of the above?
That's a great question. So I would start just with a simple definition about what is trauma. And trauma is a real or perceived experience of a threat on the life or bodily integrity of a person, or the life and bodily integrity of a loved one. So for a child, for example, trauma is not just this direct experience, but also if, for example, a parent is involved with something, right? Because they're so dependent on their caregivers. And what really differentiates a traumatic experience from a stressful experience is that trauma usually evokes a physiological reaction of horror, terror, sense of helplessness, of hopelessness. And for some kids and also adults, this physiological reaction can be even more traumatizing than the traumatic event itself. So that's a little bit the definition that we use. But nevertheless, I like to say that it's never so simple, because there might be some traumatic events that doesn't necessarily evoke that profound sense of horror and helplessness and hopelessness. If you think about, for example, experiences of sexual abuse by someone that this child really trusted, right? The feelings at that moment might be feelings of confusion. So trauma can be much more complex and very different. And what is traumatic for me might not be traumatic for you.
Right. Fascinating, yeah.
And you also asked about the different types of trauma, which is also a good question. And I think to kind of make it really simple, there are intrapersonal trauma and non-interpersonal trauma, right? So there are these traumatic experiences like physical abuse or sexual abuse or emotional abuse or neglect who are caused by someone. And especially when this happens within the caregiving system, those type of traumatic experiences can have a very long-lasting effect on the whole development of a child. And then we have the non-interpersonal trauma, which might be a war or a car accident, medical traumatic events, or COVID could be a traumatic experience for a lot of people. But this is kind of the bigger distinction.
Thank you.
So can you talk a little bit about kind of, we talked about the types of trauma, but how prevalent is trauma? Like how often is that happening for individuals?
Yeah, that's a good question. And because I'm very interested globally in how things are happening, and I can speak a little bit more about the research in the field of childhood trauma, because I believe that the children that we are seeing now are the adults that you're treating later. And so I know globally there are some staggering statistics that 1 billion of children for 1 year are exposed to some sort of traumatic event, such as physical abuse or sexual abuse. We know that the rates of domestic violence are really high. And so every 1 out of 3 women and girls might be exposed to some sort of violence at home from their own partner. The rates of sexual abuse are really high. They are around 20%. And again, I'm talking globally all over the world, because trauma it goes independently of the country, the gender, and from. So 20% is the sexual abuse. And then we also know that 95,000 of children every year die by homicide.
That is just
statistics.
Awful. 95,000 children die by homicide?
Yep. Yeah, globally. Again.
Globally. That is quite a large number. I never would have guessed that.
Yeah, absolutely. It's a much more, and I think the study actually that brought up the theme of trauma was the ACE study, which is the Adverse Childhood Experience Study. And it's interesting because it just started 20 years ago, which is not such a long time ago that we started actually talking about trauma. And even me as a clinical psychologist, I was not really trained in trauma-informed care during my master's and PhD. So this is still some sort of an evolving field, even though we know the huge impact that childhood trauma has on both mental and physical health of people. And so I would just mention this ACE study, if I may, because it's really interesting how we discovered about the field of trauma and its impact. But basically, Dr. Felitti, who was directing a clinic for obesity, so basically he was trying to help people to lose weight. He was noticing that as he was, helping people to lose weight, they would drop out of treatment. And he started questioning himself, like, why is this happening? And then one day he was interviewing this woman and he asked her when was the first time that she started having sexual relationships. And then she answered, that happened when I was 5 years old, which was when my mother started. And then something clicked in his mind and he started wondering if there is any relationship between bad things that happen to people in their early lives and some risky behaviors, such as obesity, using drugs, alcohol, smoking, self-injurious behavior, and so forth. And so they did this huge study with more than 18,000 participants, people like me and you who are just going to take their normal medical visits in the hospital. Uh-huh. And what they found out was that, first of all, more than 50% of that sample had at least one traumatic event that happened in their early childhood, which means that now from all of us that we are here online, probably at least one of us had at least one traumatic experience. So the trauma is pretty diffuse. And they also discovered that those people who had more than 4 traumas in their life, they were 10 to 12 times more likely to develop mood disorders, anxiety, substance use disorder. This is usually the third diagnosis among people who have been exposed to trauma. And then also a lot of physical conditions, such as, heart conditions and stroke and diabetes and sexually transmitted diseases and so forth. And so it was really interesting. That was the first study that kind of brought up this theme that early childhood adverse experiences could lead people to those negative coping mechanisms, which is another thing that I think this study really brought up in changing the language. Instead of seeing all these behaviors such as substance use or overeating as something crazy, and pathological, we started thinking of those behaviors as coping mechanisms, as ways that people maybe have learned to deal with the emotional pain of those traumatizing experiences. And as in the case of the woman from the AC study, maybe, being overweight was a way to protect herself from unwanted sexual experiences.
I was just going to ask a question, Lisa, of you. For us, Spectrum and New England Recovery Center, that ACEs, it's questions. I know we have trauma-informed care. Is that something that we incorporate into our clinical or?
So we do. And in fact, I actually just recently kind of asked Zlatina to help us as we're revising our forms to even include it even more. So great question. So that's exactly the direction that we're heading in. We certainly do ask about experiences, and we, certainly do integrate trauma-informed care in trainings for our staff, because we know how prevalent it is. It's the higher your ACE score, the more likely you are to develop a substance use disorder, the more likely you are to use, intravenous drug use, other high-risk behaviors, just like Zlatina talked about. And about 80% of patients in substance use treatment have a significant trauma history. And so you can't kind of separate the two, right? They're so interconnected. And those traumas can be childhood trauma, right, that have kind of prompted this way of being in the world, right, this way of coping in the world. And also there's often ongoing trauma, right, with the individuals that we work with, but that is often related to the substance use, right? Putting oneself in unsafe situations related to substance use, unsafe living environments. There's often repeated traumas, and that can make recovery even more challenging.
Absolutely. And I'm grateful, Lisa, that you mentioned about assessment and how to ask about trauma. And maybe I can say a couple of things about that, because I find that in our trainings in the past years, professionals, any type of professionals, are really struggling in this idea of how am I going to ask someone if they had trauma. And we also know that actually PTSD is very underreported, and it's still not so well assessed, which I think that it's a direction that we need to take, because it is really important to assess for PTSD. You know, in the same way as you would go, I don't know, if you have some kind of chronic pain and you go to the doctor and they don't take a blood test, you know, that can lead to a complete misdiagnosis and mistreatment, right? And you'll be probably upset. And in the same way, if you are having some symptoms of anxiety or depression, or a person who goes in an inpatient psychiatric setting, it is really important to assess maybe where are these symptoms coming from, and if there is any traumatic experience that can actually lead to this clinical presentation. And as I mentioned, I think a lot of professionals, rightly so, are afraid and have a lot of barriers in asking about trauma. You know, one of the fears is, well, but I don't know how to ask. And I don't know if I open this box of Pandora, what am I going to say and what am I going to do? And the first thing that I would like to say is that all these concerns are actually valid. And we know we talked about the AC study, and there is also an AC screening tool. And actually in some of the states now it's a mandatory to use that AC screening tool. Yes, in some pediatric settings, for example. But the point is that in the medical field, if you do an X-ray for a bone injury, for example, that will lead you to a solution, or will give you at least a result that you can go from there. But if you assess for risk, if you assess for trauma, it doesn't necessarily tell you what to do. And so I think that before asking, we have to make sure that we know what to do with this information, because otherwise this could be highly traumatizing for patients. And so I do think that it's important to know how can we create that safe space for people. And as Lisa started our conversation warning people, you know, that could be traumatizing. In the same way, a clinician or any type of professional may say, you know, I will ask you now a couple of questions that I know can be really uncomfortable, and it's your choice if you would like to answer or not. But that's really important for me to have a better understanding of the whole picture. And so then I can make a better decision about your treatment. So starting with something like that in a very empathic and kind of safe way can be really important. But I think that asking those questions requires training, and we need to make sure that we will know what to do with this information. Maybe having this referral system like LinkIt that we can call and refer those people to trauma therapy, or having some tools in the office right away that we can work with people if they become dysregulated. So just wanted to mention that.
And it's really important to treat both the substance use disorder and trauma symptoms, because if you're not treating both, then the individual is not getting the support they need to really move towards long-term recovery, both from trauma symptoms and from substance use disorder. And often those things are treated separately, and you really need to integrate that care, right? Provide, and a lot of the things that you would do to help somebody with trauma symptoms also help with managing kind of a substance use disorder, right? So for example, TFCBT, cognitive behavioral therapy, specifically CBT is one of the most evidence-based practices, for substance use disorders, and also can be really helpful to help people understand, how their thoughts, feelings, and behaviors, related to their trauma impact kind of what the choices they make and the behaviors that we see, in helping people understand that, like kind of what might be triggering someone's trauma, also might lead them to cope with substances. And so if we just kind of don't talk about those things and see, then we actually aren't helping, right? And we lose people.
Absolutely, Lisa. And I think we also have to keep in mind that we don't have to necessarily assume that trauma leads to substance abuse or substance abuse leads to trauma. It could be this kind of a downward spiral that definitely maybe early childhood trauma can make someone more vulnerable in using substances. But then, as you mentioned, Lisa, using substances can put people in a more vulnerable place of ongoing traumas. And so this is why I think it is important to assess constantly about even traumas that are happening now for those individuals.
That begs me to ask, with these studies, do we know what, say, percentage or group of people are at risk that have had trauma that are as a woman in recovery? It begs me to wonder, I think mental illness is a large portion of it, but I wonder how much trauma exists in the recovery community. Is it like the same as the general population, or
Yeah, that's a very important question, because I think that the intersectionality between trauma and substance abuse is really big. And actually, the people that we are treating with trauma, very likely so, they might have substance use disorder. We know that substance use disorder among people with trauma is the third most common diagnosis. And what we also know is that people who are in treatment for substance use disorder, up to 60% of them present with PTSD symptoms. So actually the statistics are really high among those two populations.
Interesting, yeah.
And that leads to kind of, as a treating provider, of course you have to, be careful about, not assess it, but know what to do when you assess. But we often also will take kind of a universal precautions approach, right? So just like with infectious disease, where, you just kind of, you don't know if you walk up to somebody who just had an accident and whether there's an infectious disease there, but you treat everyone as though that's possible, right? So you put gloves on regardless. You're not doing a quiz first to say, are you at risk for infectious disease? Should I put gloves on? Like, you just put gloves on before you, intervene with that person. And so we take a very similar approach to trauma, and kind of just knowing how high the prevalence is, and it may be underreported even, that there's very likely, whether they have shared that with us or not, or whether, the individual kind of really knows that this is impacting them, very specifically or not, that's likely there and likely may be influencing their behaviors, behaviors we see in the program, challenges with kind of progressing in care, and maybe, challenges with, reducing or discontinuing kind of ongoing substance use might be very tied to kind of, their trauma symptoms. And so taking that kind of universal precautions approach and assuming that that's very likely, possible, and treating everybody as such.
Absolutely. And we also know that trauma does impact the brain and the body of people, right? And so that itself can have a huge impact on their recovery journey and on the treatment that they are undertaking, really any type of treatment. We know that people with trauma, and especially talking about complex types of trauma, which are those traumas that started on a very early age, went for a prolonged period of time, and happened within the caregiving system. Those are the types of trauma that have a huge impact on, again, the brain and the body of the people. So we have this prioritization of those domains and skills who are essential for the survival of that individual. So, for example, if that kid who was exposed to domestic violence or substance use at home, the way that he survived was by blocking his emotions, freezing and hiding and disappearing, it is very much likely so to see those behaviors later in life. Or if that same child learned to numb their feelings, maybe they'll be most likely to use substances as a way to numb the emotional pain. But then we have also this de-emphasis on those domains and skills that are not so essential for survival, right? So, for example, the executive functioning skills on the prefrontal cortex, our ability to tolerate frustration or control our impulses or regulate our emotions or think about what are the consequences of behavior, right? And so we do see a lot of individuals with complex histories of trauma that they are really good in sizing you up or maybe even assessing the situations or really good in this fight, flight, and freeze response. But they might have more difficulties around, again, thinking about consequences or thinking about their future, exploring and building their sense of self, which I think can have a profound impact on their recovery in case they have also.
It begs me to wonder, like Lisa just said, sort of, it almost feels like we should approach everyone in the world as if they are trauma based, almost like, let's just assume everyone has been affected by trauma and that's why I think it's so great that the company supports trauma-informed care for everyone, because you really don't know who is going to walk in the door. It's kind of like that little meme that is around where this is someone's full life. We only know this little bit of it, and the rest of it is like, we don't know what's behind it. I love this topic because it's so pertinent in all areas.
Absolutely. Absolutely. And I think it's also important to provide that space, conveying this message to people. I am here and I can listen to that. And I'm ready to hear what you do. Would you like to tell me, right? So it's providing that space about any potential traumatic experiences that these people might have had or are still having.
And it's also about reframing our approach with substance use patients, right? So, we often say this, right, in a lot of kind of trauma trainings, kind of going from a perspective of what's wrong with you, right? When somebody doesn't show to counseling, drops out of treatment, leaves AMA, has behavior challenges in a group setting, for example, or a milieu setting, to kind of what has happened to you, right? And so reframing kind of what that behavior might be in a trauma context. And the other thing that you said about, the impact of trauma on the brain, and we've had some great conversations about this, is that we often know, right, those of us in the recovery field that work in addiction, now see, substance use disorders as a chronic brain disease. Right, that impacts your brain. It impacts your prefrontal cortex, which is also, impacted by trauma. It impacts your reward pathways and your dopamine. And so, for individuals who have, significant trauma and substance use disorder, it's really kind of a double impact on their brain, right? And so that's maybe what is making it more difficult for that person to move towards long-term recovery, to make different decisions, right? It's not a motivation challenge, but that it's really how the brain has kind of become rewired, right? The pathways the brain has created.
Absolutely. And I was listening as Lisa Nachovitz, who is the author of Seeking Safety, which, by the way, is one of the treatments, the dual treatments for PTSD and trauma. She was saying that people with trauma and substance use disorder, they are like double trouble, right? Because those are actually people we know from research studies that they may use more hard drugs. They may have much more comorbid diagnoses because trauma leads to a lot of other kind of psychiatric diagnoses. They might be more at risk of being in and out of inpatient psychiatric settings. And they also have much more ruptures in their social life and, dealing maybe with child welfare and homelessness, just having much more also of a life impact. That's really important.
So as we continue our conversation, though, one of the things I kind of like to make sure we insert in this podcast, and this is kind of important for Cathy too, I think, is the sense of hope. And so, we've talked a lot about the challenges, the risks, a lot of really heavy topics about the prevalence of trauma. I think I kind of want to shift us a little bit to talking about the fact that there is hope to recover from trauma symptoms and to recover from substance use disorders, right? Just because it's challenging doesn't mean that it's not possible. Can you talk a little bit about kind of recovery, from trauma symptoms?
Absolutely. Yes. I think that that's definitely important to talk about the hope. And it is definitely possible to even rewire the brain, of course, depending on the age population that we work with. And that's why I love working with children and adolescents, because we know that the brain keeps developing until 26 years old. And so there is a way to rewire the brain and to offer those individuals those different experiences that will be fundamental and influential about the way that they think about themselves, the world, their future. And we know that trauma, it's a little bit like wearing these black sunglasses, and you start seeing things in a much negative perspective. But we also know from research studies and all the longitudinal analysis and everything that we see in the literature that the number one factor for healing is the presence of a safe and predictable and nurturing caregiver in the case of children, but in general, the piece of the social support, right? So having those connections with people that are safe and trustworthy and nurturing. And so I think that starting from there, it's really important, even as professionals or caregivers or in other roles we are in our lives with these individuals, providing a sense of safety. And this can come out from the assessment, starting with the questions about trauma, giving them a sense of connection and empathy, right? This idea of, I know what you're feeling. And there are some great studies from Brené Brown and Dan Siegel that are talking about this empathic attunement with people, which is this feeling of feeling felt, right? So how can I connect with you in a way that you feel felt by me? And then coping skills, providing opportunities about teaching individuals once they feel safe and stable, and we reinforce those sense of connections within, maybe between us as professionals, but also in their lives. Teaching some coping skills about regulation. And so there's some wonderful treatment out there. Yes, Kat.
That reminds me of also the other part of hope, which I hear is if you can help arrest it or treat it, and then the person has the ability to change, then it's not likely, same with substance use disorder, then it's not likely to get carried on again and again generationally. That potentially the hope for me that I hear is, okay, if I have children, they're not going to be suffering with substance use disorder, but it's also likely if you or me as the patient gets trained in what my trauma was, then I won't have to pay it forward down the line, if you know what I mean, if that's the right way of saying it.
Absolutely. Providing this space of processing the traumatic experiences and really giving that hope and the real experience that there are other relationships, and actually it is not your fault what happened to you, or you're not a bad person or broken forever or dirty because this happened to you. So I think shifting that perspective of, your story is not a broken story, it's a hero story, and using those negative events and those negative and adverse experiences as a way to empower people and fostering that sense of, so many bad things happen to me, but yet I'm here and I'm fighting and I'm making those steps and I can maybe help even more other people. So I think making that shift of the narrative, it's really important, which is actually what we do also in a lot of evidence-based treatments, CBT.
And that narrative piece, there's just so many parallels with substance use treatment that I think we can make here, right? So often, narratives, sharing your story, whether that would be in a, mutual help meeting or in a, formal sponsor relationship, or, when we interview individuals in long-term recovery on this podcast, right? Is a way to kind of, process that and continue it. Journaling, like a lot of those tools that we use in substance use treatment, are also helpful, for trauma. And I continuously kind of come back to this idea of connectedness, in that some of the things that we kind of inherently do in substance use treatment are what are needed for this too, right? So, we've said it probably multiple times on this podcast, right? But addiction, thrives in isolation, and recovery thrives in connection. And that kind of connectedness that you were talking about, Zlatina, is what we often encourage people in their recovery path to build in their lives, right? To build those new relationships, changing environments, connections, in whether it's in meetings or in treatment programs, or developing their support system, can kind of help provide that connection that's needed.
Absolutely. I love that. And I think, again, there is so much intersectionality between that sense of secrecy that it's around use disorder, but also around trauma. People keep it secret because there is a lot of shame, a lot of guilt around that. But we know, as you said, that also shame thrives in secrecy and isolation. So if we can help people to share their needs, of course, in a supportive environment and with supportive people, I think that big ghost and skeleton in the closet that have been keeping for years can shrink and become smaller. And therefore also the shame and the guilt can dissipate. So absolutely sharing and changing the narrative. That's why I fall in love with TFCBTs, because we actually ask the child to create a narrative, and it could be like a book with different chapters, but it could be a song, or it could be some kind of art type of thing, but to really say those things that happen to them and see what are those cognitive distortions or unhelpful thoughts that impacted their sense of self, and then helping them to change that.
This is such a wonderful way to kind of, end our discussion, although I think we could talk about this all day. And in fact, it's something that I have, but, so we'd love to have you back sometime to kind of continue some conversations. But, ending kind of with this idea of hope and recovery. So I wondered, Cathy, if you wanted to kind of take on kind of our typical last question.
Certainly.
Of the podcast.
I always love this question, and this topic has been absolutely amazing. Hearing what you and Lisa have to bring to the table on trauma-informed care and trauma in general, amazing. But our typical last question can be personal or business, however you choose to answer it. But we like to get a little taste of what your favorite book or podcast, either on this topic or just any topic in general, that makes you feel good, or something that would maybe inspire us more than you already have.
Absolutely. So in terms of a book, I think there is a wonderful book that it's called The Boy Who Was Raised as a Dog by Bruce Perry. And this is a wonderful book because it presents a lot of different stories of children with trauma from the perspective of a child psychiatrist. And it speaks about how trauma actually the child's mind and their ability to regulate their emotions, their sense of self. But then it also speaks about the pathways to recovery. So I think it's a really profound book and ways to understand those stories and also think about resiliency and recovery. About the podcast, I have to thank Lisa and all of you guys, because got into the podcast realm much more now that I was invited here, because I was a podcast guest. But I am also trained in mindfulness, and I have to say that from all the different interventions and tools that I know as a clinical psychologist, mindfulness is actually one of the things that really helps me to kind of anchor myself and ground myself. And I would like to talk maybe another time more about that. The podcasts that I am following are more of a mindfulness type of podcast. So 10% Happier. There are also some podcasts like Wisdom, I think. I'm not sure if it was the name, with John Kabat-Zinn and some great folks that are talking about mindfulness. But also, I really like a couple of psychologists. One of them is Esther Perel. and she's really wonderful in talking about more of a relationship issues. And the other person is Brené Brown, which I actually cited today during my talk a couple of times. And these are a couple of those that I enjoy.
Those are beautiful. I can say from the take of someone in recovery, it's so informative, everything that you have to say. And it sort of makes me want to go to one of those mutual help meetings with a different frame of mind as a person in recovery, seeing other. I think what you offered me for hope today was empathy, because we really don't know what exists in people. So from my personal take, thank you. And I'll let Lisa offer her clinical side of it.
So, this certainly won't be our last conversation. Spectrum and New England Recovery Center are doing some wonderful work with Zlatina and the UMass Child Trauma Training Center. So I'm just fortunate that we get to kind of continue to have this conversation. We'd love to have you back to talk about mindfulness. That's also one of my passions. And I just really want to thank you for joining us, from the other side of the world, right, from all the way over in Bulgaria, and being here. This is one of the best things about the virtual world that we live in, that we were able to do this and have this conversation. So thank you so much.
Thank you so much. Thank you, Cathy.
It's wonderful to have you.
Best talks ever. And I think the positive energy that comes out from this talk can be really representative of the hope, actually, that we can bring into both these worlds of trauma and substance use. So thank you so much. I would love to come back.
Thank you. Have a beautiful evening.
Okay.